Good morning, everyone, and thank you for joining us today. We welcome you to our infectious diseases in cancer care session. Excuse me. We have an excellent lineup of speakers for you today. We'll be joined by Dr. Alia Baloch from the US and Dr. Fester Mahmood from the Aga Khan University in Karachi. Our first guest speaker is Dr. Alia, joining us from Florida, USA. Thank you so much, Dr. Alia, for joining us. I know it's around 11 p.m. in Florida. The topic of her talk is infections in allogeneic bone marrow transplantation. Over to you, Dr. Alia.
Thank you for the invitation tonight. And yeah, it's 11 p.m. I did take a nap so that I could be awake to give the presentation. I had to do the math a couple of times and make sure I'm like, what time do I have to present? So just starting my slide set. Is everyone able to see my slides?
Yes, if you could go to slide share.
Yeah,
Yeah, good.
perfect.
Thanks.
Let me just videos to the side. Perfect. So we're going to talk about infections in allogeneic stem cell transplant and CAR T patients as time allows. I have no conflicts of interest to disclose. As always, I present on behalf of the stewardship team from my hospital. We're going to talk about an introduction to allo stem cell transplants. Then we'll talk about bacterial, fungal, and viral issues, and then a little bit of an intro to CAR T and infections in CAR T. For those of us who don't necessarily take care of a lot of allogenic stem cell transplants, we always have to start with why is a transplant required? We originally tried to look for a family member, especially the ideal is a match related. And though there's much more up and coming data for the haploidenticals, but they tend to create a lot more infectious complications. If there is no familial match, we do look for in the registry, there's match unrelated, mismatch, and then if you have 0 adults in the world that will match you, we will look at double cords. From an infectious disease perspective, they are the highest risk. This is information from the CIBMTR, just talking about that in the United States, stem cell transplants continue to increase for both autos and allos, and that with that comes more information, for example, causes of death for match-related sibling. And here is infections at 21%. This is within the first 100 days. If you look at, reasons or causes for mortality 100 days post-transplant, it does drop down to 12%, but still a significant issue. If you then also look at causes of death for unrelated donor stem cell transplants done in 2016 and 2017, infections are here at 27%, whereas at 100 days it's 15. So this is just an example that infections continue to still be a big problem despite the current technologies we have available to us. A lot of times when we talk about transplant, whether it's for organ transplant or for bone marrow transplant, we talk about the net state of immunosuppression. We have all the drugs that the transplanters use on one side compared to our infectious risk, as well as the risk of secondary cancer, as you can see there. So as they push on, for example, the graft versus host disease arm, then we know that there's going to be more infections coming down the pipeline. I really like this depiction because it kind of in a different perspective, the risk of infections from the recipient side, increased age of the recipient, increased duration of therapies. Did you get 1 induction for AML, 2 inductions for AML? Did you get Ruxo or what we call Jakafi? Do you already have iron overload, increased risk for mold infections, for example? Your prior exposures, whether or not you're selecting out for drug resistance or just selecting out for C. diff as an example, exposure to endemic or geographically associated infections, this would be like your histoplasmosis risk. And then transplant type, as I mentioned, we're seeing definitely more viral issues with haploidentical donors. T cell depletion is a big issue as well. Then if the donor itself is increased age, and then what kind of tools do you have? If your lab is not able to be aggressive and use multiplex PCRs, it therefore takes a longer time to make these diagnoses. Your patient could be dead before you actually have a diagnosis of what is going on. You also have to have a certain amount of aggressiveness with your pulmonary team, that they're willing to do bronchoscopy. I'm very lucky that we have a very aggressive pulmonary team as well as an interventional radiology team. So if there's a lung nodule, we can assess it, we can biopsy it, work it up for whatever it is. So that was a flyby on kind of the introduction to allo stem cell transplant, so that we could talk about kind of the chunk of infections and allo transplants. To kind of remind everybody what we use in neutropenia, this is a very old school. This is based on the guidelines from 2009 that is still yet to be updated. It's still, we use for our facility, especially fluoroquinolones, comparing and contrasting them. Cipro is the standard of care traditionally because you want Pseudomonas coverage. But if you have someone who has maybe more kind of abnormalities in their mouth or in their skin, we'll then empirically switch them over to levofloxacin, losing a little bit of that Pseudomonas coverage for the additional strep coverage. Then, of course, we have patients with prolonged QTC and they have maybe allergies, so then we'll give them ceftonir. It is obviously a cephalosporin, so then there is no Pseudomonas coverage with ceftonir, but that's the next best option we can get, and at least we'll cover all the kind of Enterobacteriaceae that also are causing problems. In terms of neutropenic fever, it's still very basic with cefepime, piptazo, and meropenem. Remembering, of course, that if you have ESBL, based on the Marino trial, now meropenem is a drug of choice. This actually even came up, I just did my recertification for IDSA boards yesterday, and that was one of the big things that they were pushing, was what to do with these drug-resistant organisms. And the key thing is, even if it's susceptible to piptazo, you should be using meropenem for mortality benefit. So kind of moving on, we talked a little bit about bacteria. What about antifungal? Well, in order to talk about antifungals, you need to understand where do our drugs work. This is just a graphic I had put together for echinocandins, reminding everyone that it's against the glucan in the cell wall. Then on the top of the slide, you have amphotericin-based products binding to the ergosterol, leading to pore formation. Azoles in the bottom right-hand corner. This is our variety of triazoles and the older fluconazole against ergosterol synthesis that's in the cell membrane. And then in the middle of the cell, we have our pyrimidine analogs like flucytosine. This is a great one that I like to go over with people about comparing and contrasting our different antifungals, because it's based on that. You can kind of see also what are the potential side effect profiles, what are the potential complications you could have. So contraindicated with already prolonged QTC, because understanding that our bacterial prophy already is often prolonging our QTC, would be our Vori imposa. If it's contraindicated with short QTC, that's your isoflurconazonium, also known as Cresemba. Hallucinations, this is mainly all about the voriconazole, but I try to remind people that when you discuss it with patients, to describe it more as like visual alterations, because yes, it is 30%, but the majority of patients, they take the tablets and within 30 minutes, they see like a halo around the lights. That's really not the same as like, oh, I see lizards running across my floor when there are no lizards. So it's always good to double check. I do live in Florida. We do have a lot of lizards. Nephrotoxicity, obviously amphotericin products of all variety, whether it's Abelset or Ambizome. Nephrotoxicity, which is a theoretical risk, is for IV voriconazole because of cyclodextran. Traditionally, voriconazole is the main anti-mold therapy that we pull levels on. You can do it anywhere between 5 and 7 days. Personally, I go with 7. So that way, if we do it at 5 and they're like, oh, it's low because it was too early. And I'm like, I'll just do it at 7. If it's low and I need to change the dose or change the drug. Drug-drug interaction, the reality is all of the azoles can have drug-drug interactions with our immunosuppression, whether it's tacrolimus, cyclosporin, or sirolimus. Photosensitivity rash, this is a big deal, especially for areas that are hot and sunny, Florida, Karachi, Lahore, that I have patients that simply while driving, you can see the burns on their hand because of the voriconazole in their system. Transaminitis, again, all of the azoles because it is broken down in the liver. Fluoride accumulation, this is a very important caveat that, so for traditionally for fungal pneumonia, we'll treat for 3 months. But if you say are still meeting criteria for anti-mold prophylaxis or secondary prophylaxis, that especially once you hit the 6-month mark, there's a side chain in the voriconazole that has fluoride, and it can accumulate in the bone, leading to periosteal lifting, bone pain, and actually also like limb swelling. It's a rare side effect originally described in the pediatric sector, but still very important to know, especially for prolonged exposure. I integrated this because we just presented this at IDSA last month. At my facility, we actually got rid of posaconazole. We took it off of formulary. And so we just had voriconazole and isovoriconazonium or Cresemba. Now, both of them are FDA approved for aspergillus, as well as Cresemba has pretty much the same coverage as Posa. But what we wanted to know was, what about the breakthrough of aspergillus? Like, it's not technically FDA approved for primary prophylaxis in this situation. And what we were able to show actually was that it was not statistically different for our breakthrough rates of invasive fungal infections on the current guidelines for like possible probable. And so that's why I had interjected that here. Just to remind everybody, for pneumocystis, because we are talking about transplant, there is a risk for pneumocystis, that these are standard drugs that we use. A couple words about dapsone to remind everybody, of course, before you use dapsone, that we should order first G6PD. I actually just had a patient that resulted today with a G6PD of 1.6. Obviously, that's way too low. I put it down as an allergy so that nobody accidentally gives the patient dapsone and tries to kill the patient. This is actually another subject that is consistently every year on the ID boards, is this concept of the hemolytic anemia and hypoxia that can occur with dapsone. In terms of inhaled pentamidine, we used to use a lot. You only have to ask, do you have asthma? Do you have bronchospasm? Because it can cause bronchospasm and vomiting, aspiration, potentially death. But now with COVID, actually, it's totally been taken off of most hospital formularies, because you're not supposed to be giving inhaled drugs if you don't have to. And so actually my whole facility, we went the way of pediatric transplant, and everyone, if you need pentamidine, you just get IV pentamidine, and knock on wood, no bad side effects. Everyone's been tolerating it and no issues. As one of my pharmacists said, we don't expect to go back, Baluch. I'm like, okay, if you don't want to, as long as we're not wasting money, I don't have a problem with that. A couple words about antivirals. We use a lot of it because, traditionally 2 years we're trying to suppress HSV and VZV. So I kind of made this diagram to help me remember like what is used the most often, acyclovir-based products for what versus HSV and VZV. And then as you go up this pyramid, it is more costly as well as more nephrotoxicity. So the next one up is ganciclovir, where the oral would be valganciclovir. This is against HSV, VZV. It is first line for CMV, but second line for HHV6. Then going up the pyramid further, you have foscarnet, HSV, VZV, CMV, especially in the pre-engraftment phase, because the main thing about bone marrow transplants we know is that they have a relative pristine kidney function. And so that's why we're able to pummel them harder with drugs like foscarnet in order to try to clear deadly infections like CMV. And then HHV6, it also has activity. On the top, being the most expensive and the most toxic, is cidofovir. This is also against HSV, VZV, CMV, but it also includes coverage for adenovirus and BK virus. So just kind of helping remind people that all of your higher level drugs also cover the most basic of infections like HSV and VZV. This becomes important, especially if you're looking at an acyclovir resistant HSV, which we just had another one last month. We get one about every 6 months or so because of heavy exposure to acyclovir products, multiple rounds of chemotherapy. So it's a thymidine kinase based issue. So you have to jump all the way up from an acyclovir based product to foscarnet in order to overwhelm the system. I really like this graphic because it helps remind why I have a job. So CMV as an infection is very different in terms of its presentation in an organ transplant versus a bone marrow transplant versus an AIDS patient. So yes, same infection, still immunosuppressed patients, but as you can see, as you go down the graph here, it has different presentations based on the host. I wanted to say a few words about letermovir, as is down here. It's against a different viral terminase complex. It's kind of the new kid to the block. And we reviewed it at the hospital, and this was here just to remind people brincidofovir is no longer on the market as of about a month or 6 weeks ago. So looking at letermovir, it was looking at this kind of CMV clinically significant infection defined as 300 copies or 272 international units, which was based on where the trial was. And they were looking at these high-risk populations like haplos. As I mentioned, they have a high rate of viral infections and mortality. And so at first glance, you're like, wow, this is super cool that we were able to decrease the rate of CMV significantly at the primary endpoints as well. But then this is something I would like to point out, that it does not change. It's not statistically different for CMV disease. So for the longest time, I think about 4 times we actually discussed this drug since it came out at my facility, and I kept on refusing it. I was like, no, it doesn't make a significant difference. We don't have a problem. But then as our rate of haplos, or the percentage of our patients became haplo identical patients, all of a sudden our CMV issues became more frequent. And so then this last time, which was just last month, the CMV team has now decided that we'll bring letermovir to the hospital. But no, there's still a lot of issues, that there's drug-drug interactions with no defined guidance on dose adjustments. So then the onus is on our pharmacists. There's a different resistance mutation. And more importantly, your drug number, your number of tablets you have to take goes up, because you still require HSV coverage with drugs like acyclovir in addition to letermovir, which for compliance becomes a problem. So leaving behind the CMV stuff and antivirals, we're going to talk about some common infectious complications. Now, Marcy's paper, which, yes, it's from 2009, has this beautiful graphic talking about the infections that come from pre-engraftment, post-engraftment, and late phase, which is mainly when you're escaped from the hospital and gone to the local community. So pre-engraftment is from when we've given chemotherapy to day 15 to 45. And the way I always try to teach people is like, this makes sense, because it's all about, I give you chemo, I broke down your oral mucosa, your GI mucosa, and you're going to reactivate things because you're stressed out. And so, like, for example, I went to my team, I'm like, why are we waiting till someone's neutropenic to have a herpetic outbreak? Someone's stressed out because they're coming to the hospital, they're gonna break out on the day of admission. So now we do acyclovir on admission. This is another example of respiratory stuff. You could be exposed all the time. And then aspergillus, why there's a delay is traditionally because of that 2 weeks of neutropenia that's required before you have a risk for aspergillus, whereas Candida species coming from the GI tract comes right away. And then up to 100 days, for us, our patients are still coming very frequently to our facility for the outpatient setting, and that we're watching for graft versus host disease or complications like that. And then once they're a year and beyond, it's all about, do you have chronic GVHD? How much immunosuppression are you on? Are you requiring, say, increased vigilance for pneumococcal infections? This is just another graphic from a different perspective, that neutrophils are the first cell line to come up, thankfully, because, and that's what we base our benchmark for, can you be discharged or not? So like for us, we tend to hold our patients until the ANC hits 500. Talking about common pathogens in neutropenia, this is just a reference list from the IDSA CID paper, but there are some special caveats I wanted to point out. Neutropenic fever, we are no longer giving IV Vanco to everybody, unless you have specific causes, like when you go to look at their line, is there cellulitis, is there erythema, is the person MRSA colonized? So for us, all patients on admission get a nose swab for MRSA colonization. All patients for the heme service and the BMT service get VRE tested once a week as well. And sorry about that. And so then another caveat was that if you are colonized with an ESBL or with a different type of multi-drug resistant infection, that if you have neutropenia fever, you have to use a drug that's strong enough that would empirically cover that. Now, if you don't grow out the bug in like 48 hours or whatever you feel comfortable, you can then de-escalate or narrow it. But the main thing is we don't use that off the bat. In terms of inpatient therapy, again, talk about you're able to de-escalate if you don't grow anything, vice versa. If you're having a patient that's unstable, by all means, escalate therapy. This is a little bit of a reference to aspergillus, not to forget. If your patient is neutropenic with a prior history of IFI, by all means, use anti-mole coverage. If your patient is anticipating more than a 2-week of neutropenia, like a cord, then also consider anti-mole coverage, as well as prolonged neutropenia coming in the door. So just kind of bringing this to a couple different cases. Case 1 was a patient who has AML, got chemotherapy with fludarabine and busulfan, has mucositis, had neutropenic fever. Cultures were taken, we started antibiotics. Patient started getting short of breath. On physical exam, not fluid overloaded, you know the EF is normal. So what's the likely cause of shortness of breath, and why is there impending respiratory failure? What are the organisms we're referencing? And again, because I just took my exam yesterday, this was literally on the exam, but it's something I try to teach people because this is, you always want to know the deadly issues. So what we're referencing is viridans group strep infection that is translocating from the oropharynx. And what is important is 90% will have fever with bacteremia. You have to give the VANC because you don't know about the susceptibilities. Why? Because there's a risk for toxic shock-like syndrome, ARDS, with a mortality up to 30%. This is definitely not something you want to miss, and that there's increasing issues with resistance. As you can see, they're kind of being driven by the chemotherapy, driven by previous antibiotics. The second case is talking about down here, even further south than I am in Florida, that if you had a patient who had some incidental abnormalities on vitals and so had labs drawn, patient was febrile, complaining of body aches, fever started to escalate, counts are dropping, but the kidneys are still normal. So you're trying to think of an immunosuppressed person from Florida that's febrile with a headache. And then you're like, is this bacterial? Is this fungal? Is this viral? What things are we missing? Is this drug related, something we did to him, or is it something else? So then you think about, you do your pan cultures, you do the CT, consider further invasive imaging, you do a physical exam and you realize the patient has a lot of mosquito bites. What I'm trying to get at is that in Florida, we also have issues for dengue and chikungunya. That remembering is, I just kind of, in the interest of time, comparing and contrasting these two, hemorrhagic changes from dengue is the hallmark to look for, especially in Florida, asking, have you traveled anywhere? We do have the vector for both, and that we have indigenous cases here in Florida, so it's something that we have to think about. Talk about case 3. This was a very complicated patient that had come to us from another hospital. They're like, Dr. Baluch, can you look at this CT? What's going on? And so I looked at the labs and I was like, well, so far that's not so exciting. And then I was like, well, this CT though is, and I was like, that is a very dense pneumonia on the right side. And I was like, what happened here? So I was like, I need some help from my pulmonary colleagues. And I was like, okay, is this cap, hap, what type of stuff is this? Is this a foreign body? Did you inhale a marble? What were you up to? So I called my people and I was like, I need a lavage with biopsy. And as you can see, this poor man got lots and lots of bronchs with lots of biopsies. And it just showed this atypical squamous metaplasia. But after the last biopsy, we were actually able to clear it out. Why? Because it was simply a physical impediment that when they removed this metaplasia, then the lungs re-expanded and then he got better. And then we were able to get him to go forward to transplant. So not all pneumonias are necessarily infectious. They could be post-obstructive. I have to give a couple words about de-escalation because that's one of the big things that as part of stewardship in cancer patients that we do is de-escalation. So we looked at 120 neutropenia patients. It was retrospective that if you had a fever, you got escalated cultures, antibiotics, But then if you defervesced, your cultures are negative and you were stable, obviously, then we de-escalated you and looked at, how did you do? Did you have any difference in mortality, length of stay, ICU admission, re-escalation or bacteremia? And there was no difference. So that it showed that it was very safe to do this type of mechanics of de-escalation in our patient population. So that was a very fast overview of infections and allos. With the remaining minutes, I just want to talk a little bit of kind of the evolving next step level of care. That we do standard chemo, we do surgery, radiation, but now it's becoming more and more about immunotherapy, which makes it a lot harder to guess what type of infection is going to occur. That you're not only having these special CAR T cells that are being generated to destroy the tumors that are often drug resistant, but we're also having to think about the side effect profile. There are now 2 FDA-approved CAR T therapies. So as you can see, Axicel and Tisangelis-Crucil. I swear they do this so that you always use the brand names. They make these names so difficult to say. But what it is you take an autologous blood collection, you do the special work to kind of make the product. We then give lymphodepleting chemotherapy, so usually fludarabine and cyclophosphamide, and then we put these T cells back in the patient, traditionally for us on the inpatient service. Because literally the day that you put the cells in, you start to have significant fevers. And these fevers often come in 2 flavors, either cytokine release syndrome or neurotoxicity. And here just some generic kind of commentary, but then going into further detail. Cytokine release syndrome, you do your fever workup, rule out infections at the beginning. We still give empiric antibodies. So you can see these ferritins and CRPs go straight up. And then we give tocilizumab, which is anti-IL-6, to bring down the fever, because we obviously do not want someone who's having a consistent fever, for example, at 104, high, to then have a heart attack simply because they're having so much cytokines spill out into their system. And unfortunately, if you blow through your tocilizumab, then you have to consider steroids. Why is this so important? Is this cytokines can lead to hypotension, hypoxia, organ toxicity, and the need for mechanical ventilation. I've seen patients require literally pressors because of cytokine release syndrome that we need to calm down as fast as possible. Then that other option is neurotoxicity, which is very kind of scary to watch because these patients, they become severely encephalopathic. You have to consult neurology. We do EEGs to make sure they're not having seizures. Sometimes they can have akinetic seizures. We do lumbar punctures to make sure there's not, again, some sort of occult infection that we're missing. And then the key thing is these are patients that get treated with high doses of dexamethasone, which actually then increases their risk for infection. We looked at our series of CAR T patients for what was the actual infectious risk. A lot of it was being dictated by this prolonged neutropenia after the therapy that even persists at 1 year, that they often have low IgG levels, leading to a different set of infections, and that approximately 13% of them required IV antimicrobials somewhere along their kind of treatment algorithm, and that a lot of these were associated with cytokine release syndrome, neurotox, TOCI use, steroid use, and bridging therapy, meaning that they were sicker at baseline. So in the time allotted, we did go over an introduction to allos. We talked about infections in allos. We talked about a brief introduction to CAR, and then a little bit about infections in CAR Ts. But what this does is come full circle to why exactly people like myself are important is as these fields continue to get more and more narrow, more and more complicated, that we are trying to train not just general ID fellows, but then transplant ID fellows in this type of patient population to then go out to other facilities so that they know how to take care of allo patients, autos, and CAR, about these different trials that are available, how to help stewardship do aggressive type of maneuvers in these patients, because otherwise general practitioners oftentimes they're like, well, these are complicated patients, and I'm like, well, this is all that I do every day. And so with that, I would like to say that I couldn't do this without my team. It definitely takes a village to be smart. Smart is kind of the mnemonic for the stewardship team. And that to remind people that there are free teaching resources from USF ID podcasts, and that to follow on Twitter, there's a lot of us talking about ID related issues, and that I have a teaching Instagram account now that I finished my exam, that I do Q&A questions at least 3 times a week. And then with that, I say thank you and open it up for questions.
Thank you so much, Dr. Alia. That was an excellent talk and a great recap of infections in transplant patients. We'll now be moving on to our second speaker because we'll be taking questions at the end of the session.
Perfect.
So our second speaker is Dr. Faisal Mahmood. He's an infectious diseases consultant and an associate professor of medicine at the Aga Khan University Hospital, Karachi. And he will be presenting on invasive fungal infections in neutropenic patients. Over to you, Dr. Faisal.
Assalamu alaikum, everybody. so I must say, this was a great overview. I was blown away by how much we covered in half an hour. It's amazing. And I was stuck with the same sort of a conundrum of fungal infection in neutropenic patients. And when I was given, I said, so how many days do I have? And it was like 30 minutes. So what I tried to do is sort of summarize things and actually just focus on some other things which are questions which come up really in rounds, etc. And sort of also go back to the basics, because sometimes we forget the real basic things. And I think Dr. Ali's talk would really actually helps me, because some of the concepts you started off with, I'll just take one step back and one step further and elaborate a little bit on it. I've kept my talk actually a little short so that we save time, and I feel question answers are probably the place where most of these things get hashed out a little bit better. So the game plan is, like I said, a little bit of basics. It's always nice to review the fungi. Again, we forget the poor fungi for the bacteria. I'm going to talk about some of the things that are associated with Candida and neutropenics, just the particular things about Candida and neutropenics, not everything. And then focus more on the molds. What are the updates in the diagnostics and the updates in the treatment, and especially the different types of treatment, preemptive, etc. That sort of come up, which is something that we, at least in Pakistan, have not really embraced as much as we have in the other parts of the world. So back to the basics, the fungal family. Remember, they're not all the same. There's the yeasts, which are, I tell my residents, these are like really big bacteria. They're single cellular. They divide by division. And in this, you have Candida, you have Cryptococcus, you have Malassezia, and a bunch of others. I put Malassezia separately just because I like saying Malassezia furfur. It just sounds cool. And then on the other end of the spectrum, you have the molds. So the molds are actually like little plants. You have the stem and you have the hyphae with the fruiting bodies, and this is where Aspergillus sits. You have mucormycosis, and then you have your dermatophytes and some of the other less common molds. And in the middle of these two sit the dimorphs, the two morphologies, and these are all your endemic mycoses. So obviously for when you talk about neutropenics and talk about neutropenic fungal infections, I think the ones we focus on really would be the Candida and the yeasts, and then these molds over here. Obviously, Cryptococcus is possible. I did not put PCP over here. I never really know where to put it. I guess it's a yeast, so that's important. But these are the four big ones that we think about. And then on the other end, when you talk about the antifungals, and Dr. Ali spoke about this already, you have the polyenes, you have the azoles, and you have the echinocandins. And if you go over and flucytosine, and if you go over the mechanism of action in a little bit more detail of how they work, and this actually builds up nicely on Dr. Alia's slide. This is the fungal cell wall, and in the cell wall, they have a number of things. They have these manoproteins and this crisscross of beta glucans, and these are almost like your peptidoglycan layer in the bacteria in some ways. Then you have chitin, the same thing that's in your nail, and then you have the cell membrane, which is pretty much in all of the all living things, I guess. So the way that these cell membrane works is that you have squalene, from which you make this ergostrol, and ergostrol goes and hooks up into the cell membrane. And this really is something we see in fungi only. And the squalene synthesis is blocked by the azole right over here. So this is how azoles work down at the cell membrane, while the polyenes like amphotericin actually just punch a hole. So they bind to ergostrol and punch a hole in the cell membrane. So there used to be this sort of concern that, maybe azoles and ampho may be antagonistic, because obviously you're working on the same sub-target site, but that really didn't come out to be true when you look at clinical studies. On the other hand, icannocandins work at a completely different place, and that's the 1,3-glucan synthase. And over here, what is happening is that this enzyme is making these strands of beta-glucan, and this is where icannocandins sort of block this. So a completely different site, and that's where they can potentially be synergistic, but again, not really shown per se in clinical studies. And then finally, the antifungal spectrum, and I won't talk about the side effect profile, but it's always nice to sort of keep this in mind, that amphotericin B is obviously broad spectrum, but even though we do mention this in mucor, it's not sort of the best drug for mucor. Mucor is tough to kill generally anyways. The fluconazole, I think mostly as a yeast drug, while itraconazole adds a little bit of mold, especially aspergillus, onto it. And voriconazole broadens this slightly, a tad bit, but is obviously more potent against aspergillus. Posaconazole sort of broadens this more to cover mucor as well, but remember, again, not great for mucor, nothing really is good for mucor. And istilconazole, Alia spoke about quite a bit. And again, it's not primary for the molds, but as she mentioned, but it does cover the molds. The icannocandins, I just think of icannocandins as more as aspergillus and candida, but really candida is where they shine over here. So a quick sort of an overview of the antifungals, because this is where when we talk about treatment, I guess you need to know what covers what. So candida, and just 3 slides on candida, just because there are some nuances in the neutropenics apart from the others. And to remind you, candida is really different from the molds, so that's why I sort of put this in as a reminder. And the key features over here is that candidemia, as opposed to the immunocompetent hosts, can lead to disseminated candidiasis. And we've seen these dialysis patients with Lyme who have candidemia, and really are sitting up nicely without really any issues. But with the neutropenics, they can really cause a bad disseminated infection. Another sort of peculiar infection they see is hepatosplenic candidiasis, which is more of a chronic infection, where you'll see these sort of these sort of hypodense areas in the spleen and in the liver. And the other important thing over here is that when a line is present and you have candida in the blood in a neutropenic patient, don't always think of line as the source of the candida. This is something that we, in the non-neutropenics, if somebody has a line as candida, then it's almost certainly a line infection, but that may not always be true with the neutropenics. In treatment, the initial therapy is icannocandins, but unfortunately, as we all know in Pakistan, icannocandins are cost prohibitive, and for the most part, and also availability is a major issue. So you can go for liposomal amphotericin, and even that is also not very easy to come by. And unfortunately, as we all know, a few months ago, even amphotericin was short in the market, so we didn't even have that. So you can use fluconazole, but keep in mind that if you use fluconazole, the dose is high. It's the 800 milligram dose of fluconazole, not the low dose of fluconazole. And then as a step down, once the patient's better, you can actually step down to 400 milligrams of fluconazole, or you can move to Vori, and Vori if you're also considering a mold infection. So either of these would work. With Vori, obviously, therapeutic drug monitoring is important, levels are important. And also the availability of doing levels within the country is actually limited and is actually not very frequently done. How long to treat people with candidemia and neutropenics? Well, generally we say 2 weeks from the last negative culture. That's what the guidelines say. This may actually change. And also resolution of the neutropenia at the same time. 3 other things to keep in mind with candida is, one is eye exam to rule out endophthalmitis. This is something that we always forget. And I've had our eye colleagues sometimes say that, why are you sending this patient? His eye is fine. But remember, this may be asymptomatic. So it's always good to have a look at it. And your length of therapy duration will really depend on if there's endophthalmitis or not. Line removal is not a must, and this really depends on if you feel the line is the source or not. This is a tough call, actually, sometimes. But unlike in the non-neutropenics, in these patients, sometimes we may keep the line. Time to positivity may help you in deciding if this is a line infection or not. We obviously don't have quantitative cultures for Candida. And then if somebody has persistent candidemia and there's non-resolution of neutropenia, you may use GCSF in these folks. So just a couple of lines of Candida and candidemia in these patients. I kept this short, except for the one last thing, which is hepatosplenic candidiasis. And in this, remember, the treatment is much more prolonged. And you continue until the lesion resolves on the X-ray, or sorry, not the X-ray, the ultrasound or the CT scan, whatever modality you're using. And if they're not resolved and the chemotherapy is due next, then you don't have to delay chemotherapy. You just keep the treatment going. And this I found interesting. I sort of had forgotten this until I was reviewing this last night, that, the fever can be prolonged. And if the fever is prolonged, you can actually use NSAIDs. Sometimes we fall in this trap of spiraling empiricism where, when the fever keeps going, we keep adding on and on and on antibiotics. But keep in mind, in this case, the fever can actually take quite some time before it can come down, and you can just use NSAIDs to control it. Drug options are pretty much the same as candemia. I won't just list them again. But let's go to the molds, and molds are actually more problematic because their diagnosis is tough and their treatment is not as straightforward. And again, this is just to remind everybody that we're now talking about a completely different set of fungi over here. When we talk about diagnostics, cultures really are good for Candida, but not really for molds. So blood cultures really won't grow molds. A pet question from my fellows tends to be which mold will come up in a blood culture, and this also comes in the IT boards every now and then, and the answer is Fusarium. And a tissue culture may not always be positive in case of a mold infection, because, as my microbiologists have explained to me, when you have all these hyphae and you take a tissue culture, these hyphae may actually break, and it may be tougher to grow the mold in this case. Sputum and BAL are more sensitive for molds, but you may often have false positives, and sputum especially, because we often will grow molds in sputum. We have a lot of spores in our mouth, and a positive mold may not always mean that this patient has an infection. And same actually goes for a BAL. Having said this, if you see hyphae on a gram stain, then that usually generally means that just pay attention to whatever's growing over there. Histopath can differentiate mucor from other molds. So mucor has this very typical sort of broad-based, almost like somebody's dropped a ribbon sort of folding structure, but not other molds, because a lot of the hyaline molds, so that's Aspergillus and Fusarium and the other ones, they look very similar on histopathology. And that's where you get stuck. So sometimes, it may look like Aspergillus, but it may not be Aspergillus. And I've actually been burnt the other way around too, where histopathology reported aseptate hyphae. And I'm thinking this could be mucor, but it actually was Aspergillus, because in some of the Aspergilluses, I guess, the septate are really, really far apart. And it really helps sometimes to have a microbiologist review the slide and to give their opinion. Radiology, so chest x-rays are really insensitive, so there's no point really for Aspergillus early on. And HRCT is very sensitive for early disease. And the way that the progression occurs is that you first see a nodule with a halo around it, then the halo will disappear and you'll be left with a nodule. And then eventually the nodule gets bigger and necrosis, and you see this crescent sign. So keeping in mind that, if you're seeing a nodule with halo, that's actually a good thing, because that means now, you've got this early and you can treat this patient early. And that's why in studies, a halo sign actually is a good prognostic marker when you come to therapy. Galactomannan is something that I actually see misused a lot in at least my center, especially in the non-neutropenics. And this is a fungal marker only for Aspergillus for the most part. There are some other hyaline molds which can give you a positive galactomannan, but for ease, Aspergillus is pretty much the one you think about. Remember, you can do this in serum and in the bronch, and for the pulmonary infections, the bronch sensitivity is actually higher than the serum sensitivity. It is specific but not sensitive, which means that a negative test does not rule out Aspergillus. A positive one, you should take more seriously. And really, the population has been optimized in is the neutropenic patients. And, when somebody shows me a negative galactomannan for a non-neutropenic, I really don't know how to interpret it, or even a positive one sometimes, because you can see false positives with beta-lactam antibiotics, especially piptazo. And this is variable because it depends from batch to batch of these beta-lactam inhibitors. And some of the new ones now actually, or the newer batches from what I've heard, and I don't know, I don't know if this is true or not. Actually, they're trying to limit this false positivity. It does have prognostic factor. The higher the level, the worse off the patient may be, because higher fungal load, obviously. On the other hand, beta-D-glucan is also a fungal marker, which is present this time in all fungi. So this is non-specific. But remember, it's not in mucor. So a negative beta-glucan does not rule out mucormycosis. And it's about 50% in Cryptococcus. And the last mold in which you may not see beta-glucan is blastomycosis. And we don't see that in Pakistan, so I just didn't mention in the slide. But remember, it's sensitive, but it's not specific. So a positive beta-glucan may actually be a false positive, unlike galactomannan. Obviously varies from organism to organism. So remember, galactomannan is specific, non-sensitive, and beta-glucan is sensitive, non-specific. So that's a really important distinction when you're interpreting these results. And this was actually put together by one of our mycologists and myself. We sort of discussed this. And if you have a radiology which is suggestive of a mold infection, and your galactomannan is positive and your beta-glucan is positive, then this is almost likely to be aspergillus and treat with voriconazole, which is the drug of choice. On the other hand, if your galactomannan is negative and your beta-glucan is positive, keep in mind that galactomannan can have a false negative result because it is non-sensitive. This is possibly an aspergillus and you treat with voriconazole again. On the other hand, if all of these are negative and the CT looks like it's a mold infection, then think of mucor. And in this case, you use amphotericin B. But what if the CT wasn't done, or if it doesn't look like a mold? And in this case, there are more possibilities. So if both are positive, then likely aspergillus, maybe in a different site. Again, treat with voriconazole, you re-image in this case. On the other hand, if it's the other way around, so here your galactomannan is positive, but your beta-glucan is negative. Remember, beta-glucan is sensitive. You should not see a false negative result in this case. So think maybe it may be a false positive and do serial levels in this case. On the other hand, if it's the other way around, if galactomannan negative and beta-glucan positive, in this case, think of candida, especially if your CT scan did not show any mold over there. And you may consider treating with fluconazole in this case. And then finally, if all of them are negative, and your CT is also negative, then you may think this is not a fungus, and you may consider stopping the antifungal. So really, interpretation depends on knowing which will be positive when in these patients. Finally, there are other ways of diagnosing fungal infections. You can do DNA sequencing. This is faster. Compared to cultures, the results need to be compared with the database. You can do MALDI-TOF. We don't have MALDI-TOF here as yet. Again, you can identify the fungi in 96 to 97% of cases. And then finally, there's the T2MR, again, not available over here, can be done in blood. It is FDA approved for some of the yeast. This is for yeast predominantly, high sensitivity and specificity over here. And then the cryptococcal lateral flow assay, which is what WHO is also sort of trying to promote because of it's cheap, it's point of care, it's a dipstick, and can be done in blood, CSF, and urine, and doesn't really need straining or storage, and also very high sensitivity specificity in the CSF for cryptococcus in this case. And I'm going to end up with treatment options, and I'm just going to talk about 2 or 3 things. One is preemptive versus empiric. And empiric therapy means that you start therapy for all neutropenics after 5 days of therapy. For me, this would be the classic teaching when we were in med school, and this is called the fever-based or the sort of plan. And then there's preemptive, where what you're doing is doing progressive surveillance of X-rays and galactomannan and PCR and treat only if it's positive. The advantage of doing empiric therapy is that there's no delay in starting antifungals. It's logistically really easy to do. You don't have to do a lot of expensive tests to do this. But the disadvantage is that these patients may really get antifungals, especially because a lot of them are not available. And the only one available often is amphotericin B, which can lead to toxicity, resistance, and maybe even cost, because amphos now become really expensive. With preemptive therapy, you're only really treating those who have an invasive fungal infection. That's a great thing. But unfortunately, it is logistically tougher to do, the delays in therapy, and then the test may not be available. So the question is, which is better? And there have been, there was one meta-analysis looking to see which is superior. They looked at 9 studies, and they used this combination of GM or PCR with CT scan, and just the forest plots really show that they're almost equivalent. So this is how often you will be able to detect an invasive fungal infection. Over here you can see, and I just want you to focus on the diamond, the pool over here, and really it was almost equivalent in both cases. When you looked at the mortality, there really was no, there were the number of deaths were equal in both cases. Obviously, when you look at how often you used antifungals in the preemptive strategy, sorry, I didn't mention, which is this side over here, you use less antifungals because you're using targeted therapy over here. Which means that you had decreased antifungal rates and duration with preemptive therapy. There was no increase in mortality, and the cost in this case was similar. But remember, this cost analysis needs to be done in our population as well. So what antifungal to use? And again, Alia mentioned this already briefly, and this is just building up on her last slide of this. If you have no site of infection and the patient's got no prophylaxis, then maybe this is probably Candida. You can use an echinocandin. On the other hand, if you see these pulmonary markers, you have raised nodules and markers are raised. No prophylaxis or only used anti-yeast prophylaxis, that's fluconazole, then this is going to be likely a mold, and you would use Bori or amphotericin. If there's no source of infection, there are no pulmonary nodules, the patient's used anti-mold prophylaxis, that would be voriconazole, then think of a resistant mold or resistant candida, in which case you may want to change the class of the antifungal in this case. So in summary, so antifungal therapies for neutropenics are really under evolution. There are new diagnostic tests in the horizon. We're not sure when they're going to get here. I can tell you with Malditov, we've been struggling, and we still don't have it here. Antifungal therapy is not the only option, and you need to look at the cost benefit of doing sort of preemptive versus prophylactic therapy. And I really want to add one more thing over here in the diagnostics, is diagnostic stewardship is something that we really need to think about in when to order which test, especially GM and BDGs, which are at least, like I said, ordered. And then prior antifungal therapy really needs to look at when you're choosing an antifungal agent. And I think I finished on time. Sorry. Thank you so much.
Thank you, Dr. Faisal. That was an excellent overview of fungal infections in immunocompromised patients. I just want to add that in our experience here at Shaukat Khanum, we also see a lot of invasive fungal sinusitis. So that's also an important consideration. And in many instances, we've had patients who've had positive sinus cultures after debridement with negative fungal markers. So it goes to highlight the point that you made during your presentation. So I'm actually the last speaker for this session, and let me share my screen. Okay, so in the year 2020, no talk, let alone an ID talk, is complete without mentioning or talking about COVID-19. And so this is the topic of my presentation. I'll be talking about cancer care initiatives during the COVID-19 pandemic. And this is going to be an ID doctor's presentation. So I'll be talking about ID dilemmas and perspectives. And my role at Shaukat Khanum so far has been of an infectious diseases consultant. And also, I, along with my colleague, Dr. On Raza, have led the infection control response at our hospitals in Lahore and Peshawar. So here's the outline of my presentation. I will first start with the COVID-19 timeline, and then go over the impact that COVID-19 has had on healthcare, and then specifically on cancer care. I will then touch upon controversies in infection control and clinical management. And the reason to talk about all of these is that they shaped our response at Shaukat Khanum Hospital. I'll finally be moving to our response here during the pandemic, and will conclude with some unresolved issues. So the timeline, December to January 2020. So we heard about a cluster of pneumonia caused by a new virus in China in December 2020, and we saw that it was rapidly spreading across China and moving to other parts of the globe. And there was high mortality associated with it. Infection was rapidly spreading through communities. In fact, healthcare workers were infected with this. In fact, the physician who raised the alarm for this also succumbed to this and died as a result of the infection. So this was creating panic, fear, and anxiety across the globe. There were draconian measures being implemented, travel was canceled, lockdowns were being implemented. So these were interesting times, and we had no idea that this would lead to a pandemic at that point in time. And here's when we started seeing COVID-19 in Pakistan. We saw our first case on February 26th in Karachi. And by March 24th, the governments had, announced lockdowns. We also started to see deaths associated with the disease. We started to see infections among healthcare workers and, across the board among all populations in Pakistan. Then finally, and if you look at how our cases progressed, so gradual rise, and we peaked in June. Of note, our lockdowns were partially lifted in May. We peaked in June, and at our peak during mid-June, we had about 6,700 cases. And following that, there was a gradual decline. And here we are right now, and it appears that we are entering the second wave of the pandemic. So, needless to say, this pandemic has disrupted life across the board. Every aspect of life has been, adversely impacted by this, and healthcare has been no different. So, healthcare facilities across the globe have been overwhelmed by this because the number of cases surged across the globe. People had to struggle with shortages of PPE and ventilators because, there was a mismatch in demand and supply of these, of PPE and ventilators. A lot of hospitals had to shut down regular services so that they could accommodate these patients. So a lot of non-clinical areas such as cafeterias in New York City hospitals had to be converted into COVID wards and ICUs. Patients who had to, visit hospitals due to certain illnesses, acute emergencies, could not do so because of lockdowns and, issues with transportation. And even at the end of healthcare facilities, there was a drive to do telemedicine rather than in-person visits. A lot of healthcare workers contracted the infections, and there was absence from work due to personal illness. And finally, there, services such as surgeries, which are urgent or emergent, and procedures that are required, they were suspended across most healthcare institutions. So, really drastically impacted healthcare throughout the world. Now, moving on to how this disrupted cancer care during the COVID-19 pandemic. So, it's important to note that cancer patients are a very unique population. It's a disease associated with significant morbidity and mortality. And if it's left untreated and not tended to in time, the disease can rapidly progress. And if the disease is resectable or treatable at this point in time, maybe 1 month down the line, it may not be. So it's very time sensitive. So at the beginning of the pandemic, a small case series, were reported in the literature, and they claimed that cancer patients had poorer outcomes, especially if they underwent chemo or surgery recently. Now, I'm going to use the word perceived to describe the vulnerability of cancer patients, because at this point in time, we really did not know how vulnerable they would be, especially if they had recent treatment. As a result, the cancer surgeries, chemotherapies across the globe were canceled. Screening procedures, diagnostic procedures were delayed, and this led to delayed diagnosis of these patients. A lot of patients who could have been treated were no longer treatable by the time that services resumed. A lot of countries where clinical trials were being conducted had to suspend their clinical trials because of the major disruptions in healthcare as a result of this pandemic. And in certain situations, oncologists were also redeployed to other areas of the hospital to cover, let's say, ICUs or general medicine facilities. And moving on to some specific examples of what happened during the pandemic. So there was a Canadian survey published in The Lancet where 54% of cancer patients reported that their outpatient appointments were either rescheduled or canceled as a result of the pandemic. Then in England, in March, all cancer screening was suspended And just before this pandemic, or sorry, just before March, about 8,500 individuals had tested positive on initial screening tests for cancers, for colon cancer. And you can imagine that this one move in particular left 8,500 individuals untreated with with potentially undiagnosed malignancies at this point in time. And according to COVID surge estimate, a total of 2.3 million cancer surgeries would be cancelled worldwide. So you can imagine the huge impact this would have on cancer patients. And they also estimated that following resumption of services, if hospitals were to increase their capacity by 20% and increase their activity by 20%, the backlog caused by these cancellations and suspension of procedures would still require about 11 months to clear. And obviously, this had a very bad impact on patients as well. Firstly, there was fear and anxiety among cancer patients themselves. They know that they're a vulnerable patient population. They're immunocompromised because of their immunosuppressive therapies, their chemotherapies. They're always, instructed to come back if they have a fever or cold. So they're well aware of the clinical situation. So they were scared to come to the hospital because, coming to a hospital puts them at risk for exposure to others and contracting the infection themselves. Again, they perceive themselves as a vulnerable population, as they are. And for people who were called in for appointments, their care was disrupted and they were unable to access care because of the reduced intake of patients across the globe at healthcare facilities. And what added fuel to the fire was lockdowns and the lack of transport options because of which patients were unable to commute to the hospital for their appointments. Again, there were delays in diagnosis and treatment of cancer patients, and poor mental health outcomes were reported. Patients were depressed because they weren't able to see their physicians. They were not able to get the care that they should have gotten in emergency room visits. And again, this also led to poor clinical outcomes. So following the few initial case reports that came out claiming that cancer patients have a worse prognosis and worse clinical outcome compared to the general population, this was one of the first large studies that came out describing the clinical characteristics and outcomes among cancer patients. An 800 patient cohort study that was conducted across multiple cancer centers in the UK. And what they saw was that about half the patients had presented with mild symptoms. Only 7% required ICU care. Now, interestingly, the case fatality here was pretty high, 28%, even though at that point in time, populations across Europe had a case fatality of anywhere between 10 to 15%. So this is much higher. Now, looking at what factors may have accounted for this, so what they saw in their adjusted analysis was that age, male sex, hypertension, and cardiovascular disease were the risk factors that were associated with mortality. Interestingly, they noted that chemotherapy, radiation therapy, immunotherapy, targeted therapy, or hormone therapy within the last 4 weeks was not associated with increased mortality. Again, I want you to look at this high mortality. This is unexplained at this point, much higher than the general population. And what the researchers concluded was that it may, and looking at the, small proportion of those who required ICU care, only 7%, we know that most of these people either did not have a severe infection or they tested negative, on the test modalities that were used, or that they had advanced care directives in place because of which they did not go to the ICU despite severe infection. And, or maybe that they were denied ICU care because that was prioritized for patients who were expected to have a better prognosis, owing to their healthy condition otherwise. So this did leave a lot of questions unanswered, but a good initial step to clarify that compared to the traditional risk factors of age, sex, and comorbidities, cancer-related treatments did not appear at this point to be related to a higher mortality. Now, surgery is another very important aspect of managing cancer patients. And this is an international cohort study that was conducted by COVID Surge Group, again, published in The Lancet. And what they did see was that, and this is, just perioperative SARS-CoV-2 infection, was associated with 24% 30-day mortality. And most of this was owing to pulmonary complications. And if you look at this site, so cancer diagnosis was identified as one of the risk factors for mortality, along with comorbidities and age. So what they concluded was that you should defer surgery and try non-operative management for patients who have perioperative COVID-19. Again, you can imagine the impact of this on cancer patients. Now, moving on to some controversies in infection prevention, and I'm just scratching the surface by mentioning these three things that came up and have been coming up since the beginning and still keep coming up. And I'm sure all my colleagues will agree with me and feel for me. We feel for each other whenever we get these questions. So, firstly, what is the mode of transmission, droplet or airborne? This is one of the first questions that I asked myself when I heard about this coronavirus infection called nCoV at that point in time. And now we know so much, we're so much smarter 10 months down the line. And yet, this question has not been answered. Is it droplet or is it airborne? But, why can it not be both? In certain situations, it's droplet if the patient is not requiring high flow oxygen, not requiring aerosol generating procedures. And, if they're stable otherwise, you could consider that it's droplet. There have been papers that have come out to support this. Now, moving on to airborne. So again, you have to adopt a risk-based approach. It could be airborne if, patients are undergoing aerosol generating procedures, and if they are requiring non-invasive ventilation, procedures like bronchoscopy, high flow oxygenation, if they are undergoing inhalational treatments. So these are situations where it is considered an airborne infection. Now, a huge controversy surrounded masks, especially at the beginning of this pandemic. So first, it was, kind of recommended to not be wearing masks around and conserve masks for healthcare workers who need it most. And, as time progressed, we realized that masks are not only for your own protection, but also to protect others. So the greatest benefit of wearing a mask is if both people or everyone is wearing it, so that you're not spraying other people with your secretions. And people who are wearing masks, if the outer layer is waterproof, will be protected from secretions from other people. So at this point in time, universal masking is recommended for everyone. And thirdly, a question that remains unanswered and is the bane of my existence. What are aerosol generating procedures? So it started off with, bronchoscopy, nasopharyngeal sampling, intubation, non-invasive ventilation being characterized as aerosol generating procedures. And the list has continued to swell. I've lost count of the numbers of aerosol generating procedures. I can no longer keep track. Every professional society came out to claim that their procedures are aerosol generating, including GI procedures, FNAs, orthopedic surgeries, so on and so forth. And at this point, I feel that, short of conducting this webinar, anything else may be classified as aerosol generating procedure by someone. So, we need further data on this. We need further characterization of aerosol generating procedures. And we also need to look at the risk between, or the risk posed to healthcare workers with these different aerosol generating procedures, because not all aerosol generating procedures are the same. And moving on to COVID treatment. So remember this time when we were literally throwing the kitchen sink at everyone who was coming in with COVID-19. We didn't know if asymptomatic people should be treated or not. What is the threshold for treatment? What is the threshold for NIV versus intubation? How do we medically treat them? So these were the front runners as far as treatment was concerned. Every antiviral that's existed under the planet was thrown at these patients. We moved to anti-inflammatories and, tocilizumab, montelukast, ivermectin, plasma treatment, and obviously the front runners, chloroquine, hydroxychloroquine, and azithromycin, which I'm happy that we have data now to recommend against using these therapies. And all therapies actually listed here have not been proven to be effective. Some are still under investigation. I will now touch upon treatments that have actually shown some benefit thus far in clinical trials. And since there's a time limitation, I will only touch upon dexamethasone and remdesivir. And just to add that cancer patients are not treated any differently for COVID-19, and therefore I'm only covering the drugs that you hear about that are being used in other populations with COVID-19. So this is the recovery trial. It's conducted in the UK, randomized open label trial, where they compared dexamethasone 6 milligram POR/IV with usual care. And the outcome that they looked at was 28-day mortality. Now, if you look at these Kaplan-Meier curves, the first one, so they did see an overall benefit with dexamethasone. Dexamethasone is this red curve compared to usual care. But where they saw the most benefit was among patients who were receiving invasive mechanical ventilation. So you can see lower mortality compared to usual care. And interesting to see that it's not that patients who were receiving dexamethasone did not have any associated mortality. There was still a 30% mortality, but the use of dexamethasone actually brought it down by 10%, because the mortality without dexamethasone was 41.4%. Patients who were requiring oxygenation, even if that was low flow oxygen, did benefit from this as well. And again, you can see that dexamethasone was associated with lower mortality compared to usual care. And last but not the least, people who did not have any supplemental O2 requirements actually did not benefit. And if you look at this curve, there's actually worse mortality. This was numerically significant. I'm sorry, this was numerically higher, but not statistically significant. So all the more reason to not give dexamethasone to patients who have COVID, have symptoms, but are not requiring oxygen. All right, now moving on to remdesivir. And this is one of the trials that reported a benefit of remdesivir. This is the ACT-1 trial where this is a randomized double-blind placebo-controlled trial where they compared remdesivir versus placebo for up to 10 days. And the outcomes that they looked at were time to recovery, and they defined that as discharge from the hospital, or people who were only in the hospital for infection control purposes. And looking at this forest plot on the right side, so I've highlighted the groups that where benefit was seen, and they did see an overall benefit with remdesivir, and the benefit was higher amongst patients with in the younger age groups, patients who were 18 to 40 years old, and there was no difference between males and females, and people who were at the beginning of their illness, like within the first 10 days, were found to have benefit with this compared to those who had been sick longer. And the reason for this is that in the initial phase of COVID-19, you treat them with antivirals. And later on, about 1 week later, is when the inflammatory cascade sets in, and then you should transition towards anti-inflammatory therapies. And lastly, now if you look at different levels of oxygen requirement, people who were requiring low flow oxygen were the ones who benefited from this. So you can imagine that towards the beginning of the illness, people are mostly, it may begin with an asymptomatic, with pre-symptomatic infection. They go on to develop symptoms. Symptoms may be mild, symptoms may deteriorate, may worsen, the patient may deteriorate, and they finally may land in the ICU with respiratory failure. So, if you treat them early on, that's when this trial shows that you will benefit. So I'm going to briefly talk about the Solidarity trial. This is an international double-blind, placebo-controlled randomized trial that compared remdesivir, hydroxychloroquine, lopinavir, ritonavir, and interferon beta-1a. They randomized patients equally between whichever study drugs were locally available at that site. Without spending too much time on this, because this is currently undergoing peer review and there has been criticism regarding heterogeneity of the patient population and trial designs, I will leave it at the fact that the preliminary results have not shown any mortality benefit. And once this undergoes an extensive peer review process and is out for publication, we'll know more. And now we're going to switch gears and and I will be talking about cancer care at Shaukat Khanum during the COVID-19 pandemic. So here's the data on cancer services that we provide for 2019. So if you look at our intake of cancer patients, we had anywhere between 200 to about 400 patients per month that were accepted into our system for treatment. Now, if you look at patients undergoing chemotherapy, we had anywhere between about 3,000 to 3,500 patients receiving chemotherapy each month. And patients undergoing radiation therapy, so anywhere between 4,000 to 6,500 patients undergoing radiation therapy each month. And patients undergoing surgery, so anywhere between 1,000 to about 1,800 surgeries per month. The infection control strategies that we used at Shaukat Khanum. So we began with the pandemic preparedness drills. At that point, we were calling them epidemic preparedness drills because we didn't know how the situation would evolve. And this was back in January. We conducted drills at both our hospitals in Lahore and Peshawar to prepare our hospital staff and educate them about COVID-19 and how to deal with it as far as PPE and infection control strategies are concerned. The guidelines that we mostly referred to were WHO, CDC, and NHS for infection prevention, and we used WHO guidelines for PPE. So, and I'm mentioning this specifically because there was a lot of controversy on the use of N95 versus surgical masks. We went with the WHO guidelines recommending surgical masks for usual care of COVID patients, along with contact precautions and eye protection for patients who were not requiring aerosol generating procedures. And where patients required aerosol generating procedures, the surgical masks were replaced by N95 masks. We did implement universal masking, and this was not just limited to our hospital staff, but also to patients and visitors in our hospital. So that no one could enter the hospital without wearing a mask. We did institute PPE reuse and extended use guidelines to prevent shortages. We started rationing our PPE pretty early on, and as a result, we did not run into PPE shortages, and our staff luckily never had to work without PPE at this hospital. We created a COVID document that we updated on a daily basis. With everything changing so fast, we wanted to do this to make sure that we reached out to our hospital staff and communicated the changes in policy on a daily basis. So the updated version of this, along with bulleted points on the key updates in the document, was shared through a mail with the entire hospital staff. To make sure that the channels for our COVID and non-COVID patients were separated, we dedicated a COVID ward and a COVID ICU for our patients. And we also created a dedicated triage and assessment area outside the hospital building that I will be showing you in a little bit. And apart from that, we established zones based on COVID risk. So red zone was high risk for COVID, such as COVID units, outpatient COVID assessment area. Our green zones were zones where we did not have any COVID risk, or that we know of, where we did not have any cases. And yellow zones were zones where they were either small clusters within our healthcare workers, or they were deemed high risk zones For example, our emergency room, where you don't know if someone could fall through the cracks and not go to the triage area and show up straight to our emergency room. Then we did face a shortage of negative pressure rooms, as I'm sure did everyone in Pakistan at least. So we do have 8 inpatient hospital rooms on floors that are negative pressure, 3 rooms in the ICU that were built with negative pressure. We have, in addition, in our patient areas, we have 2 negative pressure rooms in our ICUs. So, with the surge of COVID cases, we foresaw that we may need a higher number of rooms, and we actually had some re-engineering done in our COVID unit and COVID ICU, and also installed exhaust fans to create negative pressure temporarily. So this is our dedicated COVID triage and assessment area that we called Camp COVID. And this was outside the main hospital building. It was like a tent triage and assessment area. And this is what it looked like on the inside, with 8 beds for assessment and early management of COVID patients. And whoever walked into the hospital had to go through this. They would be asked screening questions and undergo temperature checks. And if they were not found to this information did not point towards a diagnosis of COVID or possible COVID, we channeled them to where they were headed. If they're there for clinical appointments, we would send them off. Otherwise, if they fulfilled the criteria and the case definition for COVID, and if they were unwell, we would shuttle them directly to our COVID units. And if they were doing okay otherwise and they were stable, we would discharge them after testing, or give them further instructions for their follow-ups. These are our inpatient units. This is our ICU during the peak time of COVID. This is our OR. This is our COVID ward, and this is just the general floor. We actually made videos to educate our hospital staff on PPE donning and doffing, and these are our infection control nurses who've been working very hard during this pandemic with us. This is a still from one of our PPE donning and doffing videos. Right. So a very important question that we had to address during this pandemic was, we are a cancer hospital, and we all acknowledge the complications and the disruptions to healthcare that can result from pandemic and delaying care. But the questions that we were faced with were, when should we curtail our services, and when and how should we re-expand? So in March, we curtailed our clinical services. We limited the uptake of new cancer patients. So you can see that went down, and we re-expanded back in May. So you can see how this red line dips and then picks up in June. Patients undergoing chemotherapy, so you don't see that dip, because whoever was in cancer care at that point in time, we did not hold their chemotherapy. They continued to come in and undergo their chemotherapy. Again, radiation services were also functional. So this dip represents, the suspension of uptake of new patients, but patients who are already undergoing radiation therapy did not face any disruptions in care from our end. So we actually suspended surgical procedures in March, and we were only doing procedures that were either urgent or emergent at that point in time. And as I said, we re-expanded back in June, and you can see how the graph picks up after that. And obviously this resulted in significant disruptions and inconveniences for the patients, especially. A lot of them were not able to travel to Lahore for their appointments, so that was a big bummer. Now, the key strategies for us for re-expansion of services were as follows. So our main aim was to make sure that even though we are re-expanding, it's safe for our patients, and that we need to shield our cancer COVID negative patients from those who have COVID. we wanted to safely minimize the number of hospital visits. So what we did was we clustered their hospital visits. So if they're coming in for radiation and they need to see internal medicine at that point in time, or they need a test or a scan, we would try and schedule them all at the same time so that they could all be done in the same visit and the patient doesn't have to come back and forth. Again, we separated our work streams for COVID positive and COVID negative patients to avoid mixing and to prevent unnecessary exposures for our patients. We instituted pre-procedure COVID testing for endoscopies, for surgical procedures, for FNAs, etc. And then same for pre-chemo and pre-transplant patients. So what we did was that for pre-procedure testing, they would get nasopharyngeal PCRs 48 to 72 hours before their procedure. And if they tested negative, we asked them to self-isolate at home. And on the day of procedure, we would screen them again for symptoms. And if they would still be negative on the screen, we would go ahead and perform the procedure. If they were positive, then we would defer the procedure and reevaluate them in 2 weeks. Now for chemo and transplant, so for chemo, as I mentioned, most of the data that came out was cohort studies and did not support suspending chemotherapy for patients with COVID. So what we did was that we met with our medical oncology colleagues, and following Infectious Disease Society of America guidelines, we actually did institute pre-chemo and pre-transplant COVID testing. Now, the pre-chemo testing was only done for hematologic malignancies, um, lymphomas, leukemias, and even if they had positive tests, we would, especially for pediatric patients, have them get intermediate chemo within the next 10 days or so to make sure that their aggressive cancers don't become untreatable due to delays due to COVID. And again, once our patients are discharged, we advise them to self-isolate at home. And how are we treating our patients at Shaukat Khanum? So again, I mentioned this before, that the treatment for COVID patients is not, cancer patients is not any different from non-cancer patients. And we are basically treating them with dexamethasone and remdesivir. We actually use tocilizumab a fair bit, but recent data has come out against the use of tocilizumab, and the IDSA actually now recommends against the use of it. And with the use of dexamethasone and remdesivir, we've actually not had to use tocilizumab for our patients anyway. We have recently seen that, the few cases that we're starting to see have done well with these two. So was there a silver lining in this pandemic? It's been a trying time for all of us. It's been life-changing. So I think the most important thing that all of us have learned, and the biggest takeaway from this, is humility. Everyone got to have a slice of humble pie during this pandemic. We don't know everything. Our systems are not perfect. This presented great opportunities for us to reflect and identify areas for improvement, specifically presented opportunities for strengthening of our infection control program. It led to many positive collaborations in research and public health forums. We actually, were the National Coordinating Center for the Solidarity Trial for Pakistan. And we are also participating in a COVID vaccine trial. So I think the infectious diseases community and the public health community has come very close as a result of this pandemic. This has helped us evaluate our situation and work towards capacity building. For example, we currently have a 13-bed ICU, and we were able to expand our ventilation capacity at our hospital to 40 beds, 40 ventilated beds. So, thinking and, building capacity. So that was actually one of the, biggest positives out of this pandemic. And then how to optimize our resources. So with the conditions that we were going through, for example, there were PPE shortages. So, the government stepped up and we started producing PPE locally. We optimized all our resources and, tried to make the best of what we had. And this is a great cartoon. I love it. This is not obviously applicable to the medical field, but basically a business company they underwent a digital transformation, not because of their CEO or CTO, but because of COVID-19. So it has definitely had some positives. And finally, there are still some unresolved issues. Now, the first thing that I heard about COVID 19 was that the situation is rapidly evolving. And guess what? 10 months later, the situation is still evolving. So, two of my favorites that are still unresolved is what are aerosol generating procedures? And is this a droplet infection or is this an airborne infection? So, two of my favorites, these are still unresolved, and we need further data to address these, further and better. Now, we need further data on COVID-19 treatment because I mentioned the few trials that have, shown benefit in treatment, but we need more robust evidence because now with the Solidarity trial coming out with such a large sample size and it was conducted across multiple countries in the world, we actually are back to square one because it hasn't shown any benefit. So we definitely need more data there. We also need more data on cancer patients with COVID-19 because so far what we have is just cohort studies. So maybe, further studies on treatment of cancer patients, what is the optimal timing of surgery once they have a COVID infection, what is the optimal timing of chemo when they have a COVID infection. So maybe trials to support that further. And when are we going to get a vaccine for COVID-19? And so far, all trials have excluded COVID-19 patients. And, so maybe down the line, we also need to think about a vaccine for cancer patients with COVID-19. And, throughout this pandemic, when I would send my morning emails with changes and, updates on infection control policies related to COVID-19, I would get emails from my hospital staff asking me, why we've gone back and changed things that were just decided on a few days ago. Things, as I said, are still rapidly evolving. And this one liner, this one quote just sums up the infection control response to this pandemic. When the facts change, I change my mind. What do you do, sir? With that, I thank you for your time and attention. And we will now be moving to questions. All right. So, Dr. Alia, we have the first question for you.
I was going to ask you a question first,
Oh,
but
sure.
sure,
Yeah,
go
yeah,
ahead.
yeah. Sure, go ahead. Go ahead. No. Yeah,
So I got to have the wonderful responsibility of co-chairing the COVID research committee at Moffitt. Um, we did a lot of convalescent plasma. Did you guys do that in Pakistan or not for COVID treatment?
So we did not do that at our center, but there were at least two sites that had approvals for clinical trials, and one of them in Lahore and one of them in Karachi. I am not aware of the results that in any results that have been published yet. We
Yeah,
did not. Yeah, we actually submitted our IRB proposal to start doing that at our site, but by the time we did that, we were just through with the first wave of the pandemic. So we don't have personal experience. So maybe Dr. Festal can share his.
So we did use CP at our center. Actually, there were a number of sites in Karachi that were using it. One big problem with the CP trials over here is that we do not have neutralizing assay. So we do not know how many neutralizing antibodies were being transfused, and we were just looking at the total antibody titers in hopes that there will be neutralizing antibodies over there. The second issue with all of these studies, actually, not just the convalescent plasma one, is that now that we know that the timing of each of these therapies makes a difference in the disease spectrum, and I feel that a lot of the patients that we were using plasma in back then were late, were critically ill, often people in which other therapies could not be used. So, the outcomes may not be the best. So we are developing we're trying to look at our neutralizing antibody titers now. Actually, we're developing an assay, and we've gone back to our patients in which we took the convalescent plasma from, and we will get that data soon in terms of how many of them actually did have neutralizing antibodies. And I looked at the prelim data yesterday, and there were actually a few in which there were actually no neutralizing antibodies. So we've got to put that together and relook at our data all over again. I'm really, really scared to give any anecdotal sort of feelings anymore. Even especially looking after the recovery trial came out, where it showed that Out of 100, 12 will benefit from steroids, and the rest will just get better by themselves. So we used it. Nobody had an adverse effect from it. That much I can tell you. Can't really tell how much the benefit.
I mean, even for us, we tended to the implicit bias of using it in the sickest patients. It actually was our AML patients who, because they were the last ones to be kind of rolled out the pre-chemo swab. And it goes back to the idea of if your patient is in blast crisis, you're not going to delay chemo. They will die anyways. And so you just kind of have to take it in the chin. And they ended up having bleeding issues related to the low platelets because they still have AML. And people forget these are very sick patients at baseline. They have a high rate of death at baseline. And you just added the COVID on top.
Yeah, so it was, luckily, we actually did not face the situation where we had someone so sick coming in and requiring urgent chemotherapy. However, we clearly outlined in our guidelines that there should not be any reason to withhold their chemotherapy, because obviously you don't want them to die of cancer rather than COVID-19, right? So it's a tough situation, and you always have to weigh the risks and benefits. So
Right.
so that's what we
would.
would do.
Second question then.
Yeah.
Did you guys, your hospitals, did you stop allowing visitors? Because for us, that was one of the first things we went after. We're like, because we were running out of reagents to literally do the COVID test. And we're like, so then we just were like locked down. We were like literally for the building, we're like, sorry, visitors not allowed, except for bone marrow transplant, because we were like, if you come in the door, you're stuck in the building for 30 days.
Yeah, we actually, that was a big thing that we did. And we actually, you know how sick cancer patients can be, and they're so debilitated and everything. So for people who were able to walk in themselves, we did not allow visitors with them. And obviously people who needed help and support, they were allowed to bring in one visitor. But even for inpatients, we really minimized visitors. So that was one of the things that we did.
We did something similar. Our hospital is slightly different in that it's a general sort of care hospital. So we have COVID, non-COVID, cancer, non-cancer, all of them there. So if you if you have COVID, then visitors are still not allowed. So nobody can visit somebody who has COVID regardless of their functional status. But we did something similar to exactly what you described, Salma, is that if somebody had, if they could take care of themselves, then no visitors. And if they cannot take care of themselves, then a visitor. But culturally, this was a challenge and still is a challenge. And we're, surprisingly still struggling with our visitor policy and implementing the visit policy because over here culturally, if you don't go visit your loved one in the hospital, you're not a good relative. So, the people keep score and you're like, you didn't go, you didn't come. So we're still struggling.
Yeah, actually, we had a no visitor policy for our COVID patients, and we still do. So what we did was, and we get a lot of pushback on that, and people can go and and you know how emotionally charged people are, especially whenever someone is ill, and you can imagine how much worse that is when someone is sick with COVID. So what we did was that we would do video calls, have them communicate via video calls with their family. We would give the family frequent updates on the clinical status. So that's the best that we could do. But we did not succumb, and we actually stuck to that policy of no visitors to COVID patients.
Very nice. Thank you.
You're welcome. Okay, so now we're moving to questions. So Dr. Alia, the first question is from you. And what's your take on preemptive versus universal prophylaxis for CMV?
So for bone marrow transplant, it's a little bit different than for organ transplant. It has to do with how strong is the bone marrow. Traditionally, in bone marrow transplant, we do CMV PCRs weekly when it hits a critical mass, and it's a hospital-dependent thing. So for us, we're international units. We say if you're more than 600 international units, then we'll start therapy. But otherwise, the bone marrow is on average too fragile to just like give everybody universal prophylaxis. Very different in organ transplant that the bone marrow is pristine. So like your high risk organs being say a mismatched CMV for lung transplant, then by all means, we'll give them universal prophylaxis. The problem is the same thing that happens with letermovir, is that you delay the inevitable, that when you stop the prophylaxis at some juncture in time, 3 months, 6 months, pick your number, then you will have the problem where you're trying to balance out because you don't have immunity, you've been just artificially using a drug. And so it will still happen. You'll still have a certain percentage that will have CMV viremias. You're just praying it won't be as severe, it won't be as dangerous, the morbidity and mortality won't be as high.
Okay. And Dr. Faisal, the next question is from you. And you did touch upon this, but if you could just elaborate on that again. Empiric therapy is recommended after 96 hours. Is there any evidence that preemptive treatment with evidence-based investigation for preemptive treatment with evidence-based investigation in neutropenic patients? Can we wait for investigations to prove fungal infection before treatment?
So I think the key thing over here is that in preemptive therapy, you're not waiting. Actually, it's not like you're waiting until they get sick enough and then you investigate and you give therapy. On the other hand, you're actually investigating before they get sick. So that's why it's preemptive and not prophylaxis. So there's a little bit of a thing here. So you can you can wait for investigation. The important thing, and I think each center needs to realize this, is that if you're doing preemptive therapy, you also need to see what your costs are. For example, beta-D-glucan, galactoman are not cheap, and what your turnaround time is. Because, for example, in our center, these are not done every day. And if the result comes back once a week, so you may not be able to do it technically, or depending on when you send it. So I think these are the sort of conversations you need to have to decide. The point is not to sort of throw in antifungals at 96 hours as your standard of care. There are other standard of cares also available at this point, which were not available way back when. I mean, these are now no longer new concepts in many ways.
Okay. And Dr. Faisal, you also commented on keeping or possibly maintaining or retaining lines in the setting of candidemia. So if you could elaborate on that, how can we find out if this is a line-related infection versus GI-related infection?
So this is a tough one, actually. And remember, lines are sometimes precious also in these patients. They can't always be replaced at the drop of a hat, even if ID says remove the line. So there are different ways of doing it. One thing for sure, if somebody's really sick, if somebody has refractory candidemia, then the line has to come out. So there's some cases where the line has to come out regardless. So if it's a temporary line, which is easily replaced, I'd rather have it out than in. But if somebody has a Poracat, for example, where and they're thrombocytopenic at the same time, and you're struggling between, does the line have to come in or come out? So remember, the line doesn't have to always come out. Time to positivity is useful. It needs a little bit of planning, at least in our institute, where you've got to tell the lab beforehand, we're looking for this, because they don't always note the time that the blood culture turns positive. And in the really short form of this is that you draw blood cultures from the line and periphery at the same time, drawing the same amount of blood, and you see which one turns positive first, the line or periphery. And if they both turn positive at the same time, or the peripheral turns positive first, and this is not a line infection. But it does need a little bit of a sort of pre-warning to the lab beforehand for this. So there are ways to retain lines in this case. My point was, think beyond the line in case of a neutropenic patient, which we often don't do in non-neutropenics.
Oh. Next question for Dr. Alia. In case of GVHD with steroid use, there are chances of CMV reactivation. Would we start Valgans like the as prophylaxis in that case, or follow PCR report and start it when we get a positive CMV PCR?
It would still be, unfortunately, follow the PCR, because say if the GVHD is GI related, you have to be careful of a high throughput through the GI tract. And so then here you could theoretically, if you're giving valganciclovir, you could be exposing the body to low dose anti-CMV drugs and therefore breeding resistance. This is why specifically for CMV of the gut, we don't try to use oral therapies. We try to only use IV. So no, unfortunately not. The one thing that we do that if you're on high dose steroids for GVHD, there is the indication for using pioposaconazole as primary prophylaxis against mold. Though to be technical, we do use all the anti-molds for the same thing, because POSA is not always well tolerated and like at my hospital, not on formulary. So though more of an expert opinion, we extrapolate that indication of using POSA as for, well, if you're on high dose steroids, which for us we dictate as 1 mg per kg of pred, that then we will give you also Vori or Cresemba, or if your insurance dictates it, POSA.
All right. And sorry, again for Dr. Alia. So we've actually recently been approached for a clinical trial with the novel antifungal Braxifungerp. Do you have any experience with that? This is from one of our ID colleagues.
That I'm sorry, I don't have any experience with. For us, because of lab stewardship, antimicrobial stewardship, we tend to be more of the old school, what is tried and true. And especially because when we do trials, the Moffitt Cancer Center, we're only allowed to have one interventional trial at a time. So the bone marrow transplant service tends to have literally a GVHD trial in every patient. So it's been a struggle to get prospective trials at Moffitt. Our first sets are the big Allovir ones for off-the-shelf T cells. And then we're looking at, there's a new IVIG formulation that's 7 times stronger than the current IVIG. But unfortunately, no, I'm not cognizant of any of the new antifungals.
Yes, Dr. Pestle.
So we are part of the Ibrexafungerp trial. It's a drug which is similar to the icannacandins. So same mechanism almost, but not an icannacandin. It is oral. We recruited our first patient just 2 weeks ago. That's all I can say. I mean, she is a patient with fairly extensive malignancy. And this is only for Candida auris. So that's what we use it in. And actually, it was a good thing we had the drug, because this patient really couldn't use anything else. She had anaphylaxis to amphotericin. The strain was resistant to fluconazole and voriconazole. And it was in the urine, so I wasn't very comfortable using caspofungin for that particular indication. So really the only option she had was Ibrexafungerp. We used it. She's back, and she may have candidemia now. But again, it may just be the disease and not failure of drugs. So, that's all.
So Dr. Fatal, literally the drug is only for Candida auris?
No, this trial is for use of Ibrexafungerp and Candida auris. They have multiple trials. There's another study. We're looking at other fungal indications, but we haven't had our IRB finished, so we haven't started enrolling in that as yet.
Okay. Well, knock on wood, thankfully, for the epidemiology for definitely the state of Florida, Candida auris, as of yet, is not a big deal for us.
It is for us.
Yeah, no, but that goes to show, like for us, we have had a bunch of histo cases. I had a gentleman who decided he was going to have a Cryptococcus gaddii. And I was like, have you been to the West Coast recently? He's like, Dr. Baluch, I don't fly. I'm like, where did you get it from? You know, so I mean, like our patients have just sometimes different fungi. Being in Florida, we have a lot of mucor, a lot of fusarium. Our patients are like, oh, I went running through the swamp yesterday. I'm like, why? They're like, because the swamp is in my backyard. I'm like, Florida, yes, the swamp. And so we have a lot of wet, icky looking feet because they wear flip-flops in the swamp. Mm-hmm. But I will say, talking about COVID, Dr. Salma, that we were really worried. Everybody was worried. I had just left Pakistan and I was worried while in the Dubai airport, Mommy, we have a problem. COVID is coming behind us. And, but our patients thankfully showed, at least here in Tampa, that the education makes a big difference. And we probably the whole time, maybe 2 BMT patients in the whole panel that I'm aware of has gotten COVID. I mean, that's phenomenal. That literally, knock on wood, none of our bone marrow transplant patients, and we're a very large program, has died from COVID. We've had some of these AML cases, some of our breast cancer patients, and we're firmly in a 3rd wave, which is very scary. But cancer patient-wise, we have been very lucky because of the education to wear the masks. They're way better than some of our staff members are when they're outside the building. So I think that's made a big difference for us in the US. But trying to get trials for COVID cancer patients is almost impossible. So vaccines, can't get that. There is one drug I will be starting a trial for, a CCR5 inhibitor, but that's taken me months to get anything at Moffitt for a COVID cancer patient.
Yeah, it's interesting. I actually just looked at our data that we are going to publish, so I'm not going to share everything from the results. But we had about between March and June, we got about for 30 patients or so with cancer. Most of them actually had mild infection, and chemo surgery, all these things were not associated with a high risk of mortality, even in our data set that we hope to publish soon. So yeah, so I think the results from that standpoint have been consistent. I really hope that we could have better characterization of treatment modalities, etc., for cancer patients in particular, especially because I'm at this hospital and I work with cancer patients specifically. Dr. Faisal, I have a question for you now. So what are your thoughts on antimicrobial stewardship, especially with regards to antifungal therapy once you've started it?
So when can we stop, or should we stop or not stop? And once it starts, it keeps going.
Yes.
so it's a tough one. I think one is with these neutropenic patients or with the cancer patients, there's a lot of fear that if you don't give them everything, they're going to die immediately. And withdrawing once they start improving is tough, and when they're not improving, it's also tough. So explain to clinicians that if you find given something empiric and it's not responding, then you can go ahead and stop the meropenem. It's been like 42 days that they've been on meropenem now for. So my thoughts are that I think the neutropenic patients and the transplant patients actually are unique, and they actually have another layer of challenges in trying to convince the primary care physicians to stop antifungals and antibiotics.
So if you have patients who do not have any radiologic evidence of disease or any microbiologic evidence of disease, but they have elevated, let's say, beta galactomannan, then at what point will you stop their therapy?
So, and I would like to know Dr. Alia's thoughts on this also. I usually don't follow markers as to when to stop therapy. And this is a trap that I have fallen in earlier on many years ago, and I managed to climb out of it. But I do know other the oncologists who've done this. So there's no point. I look at clinical response and remind everybody to treat the patient, not the labs.
Agreed. I'm not a fan of serum galactomannins. My heart hurt when you said non-neutropenic patients were gaining galactomannins. I was like, no, that shouldn't be allowed. I do like galactomannins from Bronx, but it's still the clinical gestalt. So the Cryptococcus gattii patient that I re-reviewed today because I was like, we were getting more information, is a transplant about 3 years ago, has lung GVHD, so highly immunosuppressed, had these lung nodules. We did an EBUS. EBUS came back as we were literally sending him to another hospital because we found bilateral PEs. I'm like, see you later. You could go to the other hospital. So the EBUS first grew Cryptococcus gattii. So they're like, well, we're going to treat narrowly. I'm like, sure. But it was the other hospital. I'm not going to argue. I gave him the information. So they're like fluconazole. Now, of course, knowing my luck, because he's my patient, in about a week, he started to grow aspergillus. And I'm like, wonderful. So it was Aspergillus versicolor, which is not a typical bug for us. And then to make it more complicated, third bug was penicillium. I'm like, well, penicillium is garbage. I'm like, for us, it's usually a colonizer. But the kicker was his serum galactomannan before the bronch was negative, serum galactomannan after the bronch was negative. More importantly, the galactomannan from the bronch is negative. And so I have one bug I really believe and two bugs I don't really believe, but then I'm stuck with, do I give them fluke or do I give them vori? And then you're like, well, The other issues, Cryptococcus gattii compared to neoformans tends to have a higher MIC to fluke, but we don't have the actual MIC yet. And so I hate to say it, but I chose to go with Vori simply because I'm more worried about that first bug, that treating under rather than treating above. But it comes down to clinical. And then my biggest thing that I like, which I'm probably making my patients glow in the dark, is I do a lot of CTs. And I do them without contrast. I technically don't do high res because I'm not looking for fibrosis or lung GVHD. I'm purely looking for lung nodules. So I just do CT chest without contrast. When I'm treating for mold pneumonia, for example, the 3 months, I'll do a baseline CT, 6-week CT to make sure I'm not totally missing the ball, and then one at 3 months. And I give my patients that heads up at the beginning. Then you're gonna see me minimum these number of times. And we've been caught with sometimes drug-resistant nodules that they initially get better and then they blow up. And then I'm hoping for this chappie, he's only 30 years old, that with the voriconazole, I won't fry whatever is left of his liver because he has a little bit of GVH over there. And that we'll be able to get all of these bugs under control. At minimum, one of them is an active infection. And I can't disprove or prove the other two.
Okay. And the last question that I'm going to take is about COVID reinfections. So someone asked us if we have been seeing them. So we have seen at least 9 with reinfections. And for some of these, the gap between the 2 PCRs was at least 8 to 10 weeks. We haven't proven them with genetic analysis, and we hope to be able to do that soon. But we have, and now if you guys can share your experience.
So we've seen reinfections for sure, and I actually reached out to a bunch of people because we're just trying to put this together, and without even really hunting really hard, we found over a dozen. So we're just sort of putting this together in a quick series. And there's no doubt. I mean, we currently have somebody admitted right now who's an ENT surgeon who's come back with a reinfection as well. What I can't tell, and I saw this question also, is what's the chances of reinfection for COVID, and the frequency of this reinfection. Obviously, we don't know as yet because we don't have as many cases, and it's not been systematically looked at. But having said this, this is something I tell all my patients as a routine once I'm seeing them for the last time with COVID, is that, you've had it, even if you've gotten your antibodies done, which I always discuss, but even if you got it done, you can still get it. So just make sure you keep your precautions going. You're not scot-free now, and you're not done with this, and it's not done with you.
I'm curious for you guys, are these mainly lymphoma patients who've had B-cell depletion, or you haven't really looked at that type of detail?
No, I'm talking about healthy healthcare workers.
Oh.
I've had one patient who was a lymphoma patient actually who came back with reinfection, almost certainly because we don't have the genetic analysis, but he did have negative PCRs in between and was asymptomatic in between. But the rest were healthy, yes.
Yeah. That was our last question. Sorry, what were you saying?
I was just going to say, as far as for us, I'm not aware necessarily of patients or via our OC Health of reinfection. But because of HIPAA issues, that information is also closely guarded, to be all honest.
Okay. All right. Thank you so much for your time. I really appreciate it. It was excellent chatting with you guys. Thank you so much for sharing your expertise. And we hope that we can continue to do these in future as well. Thank you. Bye.
Thank you.
Thank you very much.